Welcome to the JEADV podcast. In today's episodes, we are joined by Prof. Johannes Ring and Prof. Lidia Rudnicka, Chair of Dermatology at the Medical University of Warsaw, to discuss alopecia areata. But before we get into it...
Did you know? The JEADV started in 1987 with 21 founding members and has now grown to over 11,000 passionate advocates for patient care in dermatology and venereology. We are a diverse community with members representing 125 different countries. If you would like to learn more about our membership benefits or if you wish to join the community of like-minded professionals, go to JEADV.org.
Prof. Rudnicka will share the latest treatment guidelines from a new European consensus and highlight the emotional toll of hair loss on patients. We'll dive into fresh solutions and why empathy is key in helping those affected. Stay tuned for an insightful discussion.
Good afternoon. My name is Johannes Ring. I'm here on behalf of JEADV at the Congress in Amsterdam, doing this JEADV podcast, and it's my great pleasure to sit here with Professor Lidia Rudnicka from Warsaw. And I would like to ask you to briefly introduce yourself.
Yes, my name is Lidia Rudnicka. I'm the chairman and professor of the Department of Dermatology of the Medical University in Warsaw, Poland, and my main interests are hair disorders.
And I think this is a big spectrum. We would focus on alopecia areata today because I think there are exciting new things going on. But can you tell us about this disease, something, how common or what are the problems?
Yeah, it's not uncommon because it is calculated that approximately 2% of the population will have alopecia areata sooner or later. The disease is extremely stressful for the patients and very disturbing because it has a major impact on their life. And it has been shown that over 60% of patients make their decisions about their private life, their relationships, their job, their education on the basis of their hair loss. So this is from the clinical or the life point of view. But physiologically, this is an autoimmune disease which is causing loss of hair on the scalp, but also the eyebrows, eyelashes, beard area. And it's also worth mentioning, it is also causing a loss of the nasal hair. And the loss of nasal hair is important because nasal hair protects the respiratory system from the pathogens, but also from allergens. And this is a field where you are an extremely known and well experienced expert. And it has been shown that patients who do not have the nasal hair, but they have atopic dermatitis, they're more likely to develop earlier asthma, if they do, compared to the ones who have nasal hair. So it has been shown the bigger and thicker the nasal hair, the better for the patient.
It's very interesting. It's new for me. You always learn. And you mentioned atopic dermatitis. Is there a real comorbidity or is it just coincidence?
I think it's frequent enough to say that this is a comorbidity which is statistically significantly commonly associated. And I do not remember in detail the numbers, but approximately 15% of patients with alopecia areata also have atopic dermatitis, and many of them have increased IgE with no signs of atopy. So yes, there is an association.
My old senior professor, when I was a resident, Professor Sandro Margescu, a very good dermatologist, he used always to say alopecia areata is the eczema of the scalp. Is this true or?
This is very interesting, and I'm thinking from the pathogenic point of view, but this is intriguing to explore. Have you seen many patients with atopic dermatitis and alopecia areata?
I have some who have both, but it's not like asthma or hay fever, so. But I think there is an association. But from the pathophysiology, so the eczema of the hair follicle is it also Th2, or what kind of T cells are there?
Well, it seems they're both Th1 and Th2, but it seems that like the driving force is most probably the interferon gamma. However, it's a long pathway, and now it is also believed that there's an abnormality within the hair follicle. This is quite new. So it's definitely an autoimmune disease, immunologically driven, but some pathology of the hair follicle may be also present.
Similar to when I want to compare psoriasis, the role of the keratinocyte becomes more, here it's the hair follicle. So not only lymphocytes are important.
Definitely, and both in psoriasis and alopecia areata, there are two locations which are quite characteristic. It's the scalp, but also the nails. So it's not only a disease of the hair follicle. And maybe your idea with the keratin, who knows? Maybe it will be a breakthrough in the future. We don't know.
It's an exciting field, anyhow. So, could you tell us how the classical therapy is or was, and what is now coming new?
The problem until recently was that there was no approved registered treatment for alopecia areata. So we always treated our patients off-label. And a general rule is that if it is mild alopecia areata, we either treat with topical steroids, especially the children, and also an option is intralesional triamcinolone, which may be used in patients who have the milder form of the disease. Once it becomes moderate, and especially once it becomes severe, we should use systemic therapy. And there are not many systemic options. Of course, we know about the glucocorticosteroids, but on the other hand, we are also aware of the potential adverse events of glucocorticosteroids, especially in the large doses. So there's a tendency to use some steroid-sparing agent. And one of the steroid-sparing agents is cyclosporin. Another is methotrexate, which became very controversial recently. And there's some data, but definitely not sufficient to say that azathioprine may be also an option.
Do you also use the contact sensitizing, the ascorbic acid, or the DNCB? Or we are in Germany influenced by Rudi Happle, who was promoting this.
Yes, it gives some improvement in a group of patients. It is not available in all countries, so we do not have it. And also there's a problem of the discontinuation of the treatment, because it's easier to continue with maintenance therapy once it is a systemic treatment compared to the immunotherapy. But yes, this is also one of the possibilities.
I always liked the image or the comparison to fight, like in the wildfire in the forest, to fight the fire by fire, to inflammation against inflammation. But I never really understood the mechanism.
Well, the concept is that especially the CD8 cells, but the immune cells which are responsible for the damage to the hair follicle, that if we cause contact dermatitis, that these immune cells will move towards the epidermis and they leave alone the hair follicle, which is deep in the dermis or in the subcutis. I am not sure it's the correct explanation, but this was one of the hypotheses.
But it's a nice anecdote, maybe you know, that when Rudi Happle presented his first results, he sent an abstract to the German Society for Dermatological Research, the RDF, including a photograph of the one patient where he did a half-side treatment. And half side was just blank, and the other side was like a guard at Buckingham Palace in England. And they rejected the abstract because of lack of statistical analysis. I think that's a nice anecdote.
This is true, but it's really a nice way to evaluate topical treatments, to have like half body treated, half body untreated, and to see whether the half which is treated is improving. Yes. However, I agree, statistical significance is very important, especially currently in the medicine.
Let's become serious again. Now there are the Janus kinase inhibitors, the JAK inhibitors. Mm-hmm. Could you tell us a little bit what are these substances doing?
Mm-hmm. Yes, these are also immunosuppressive treatment, or maybe we should say immunomodulating systems, medications. However, there's a recent study which shows that the JAK inhibitors, and I will go in detail in a moment, but from the point of view of pathophysiology, it has been shown that they do not only have an effect on the immune cells, but they also have a direct effect on the hair follicle. So this gives some hope for patients who have a non-active alopecia areata with no inflammatory infiltrates, but still have no regrowth. We have currently two, in Europe we have currently two JAK inhibitors which are available. One is the baricitinib, this is a JAK1, JAK2 inhibitor, and the other one is ritlecitinib. And for ritlecitinib, we sometimes use the term kinase inhibitor instead of JAK inhibitor because it inhibits two kinases, JAK3 and the family of TEC. And TEC are non-JAK inhibitor, non-JAK kinases. But this is just about the names. It's not about the mechanism of action. They have a quite high, however, unfortunately not 100% efficacy. The efficacy, we can say, to make it simplified, is up to approximately 60%, what means that 60% can achieve a significant regrowth with JAK inhibitors, but still 40% will not respond or will be only partial responding.
How long does this take, the regrowth? How long do you have to take the drug?
There are two difficult questions in your question, because one is how long do we have to take the medication to see the first results? And we are used with steroids or with cyclosporine that once we start treatment, after a few weeks, we have a great regrowth. Unfortunately, with these old treatments, there was a fast regrowth and fast relapse. With JAK inhibitors, we wait really long for the first effect, sometimes 3 months, sometimes 4 months. And there's a group of approximately 10% of patients who respond after more than 1 year. So this is long waiting time. And now the more difficult question, how long after we have regrowth, how long do we treat? What is most important, it is a big mistake to discontinue after we have a regrowth, because then we will experience relapse. And one of the famous hair experts from Germany, Ulrike Blume-Petafi, said, we have to interpret alopecia areata as psoriasis. So if we discontinue, it is very likely that the patient will have a relapse. So there's now the tendency, and we have to keep in mind the JAK inhibitors are on the market for 2 years now. So we are still all learning. But the tendency is now that if we have a regrowth, that approximately after 2 years, but please don't take this number as a black and white suggestion, that we can start tapering down the dose. And if the patient does not have a relapse, we continue tapering down the dose. If the patient has a relapse, we increase the dose again.
So it looks like as if one has to take them for many years.
Definitely.
Yes. Okay. And what is about safety? One is a bit scared. One is reading, especially from rheumatology, about thromboembolic complications, sepsis. What is your opinion to the safety?
Well, in general, I would say JAK inhibitors, in most cases, have mild and transient adverse events. However, I think as with every type of medication, we need to first investigate very in detail the patient before starting therapy, and then we need to monitor to not miss something what is really important. And regarding JAK inhibitors, regarding baricitinib, there is safety measurement statement from the EMEA, from the European Medicines Agency, who is saying that there are certain groups of patients in whom we should be more cautious. It is a little bit controversial whether the basis for the statement is sufficient or not sufficient, but it is, so we have to consider this when making the decision about the treatment. And it says, for example, that we should not, or we should be cautious with starting JAK1 inhibitors if these are patients who have a risk of cardiovascular diseases, a significant risk of cardiovascular diseases, a significant risk of neoplastic diseases, if they are smokers or have been smoking in the past for a long time, and if they're 65 years old or older. And these are patients in whom, according to the EMEA, we should be cautious making the decision. According to the SPC or the leaflet, in patients who are 65 or older, we should not use the standard dose of 4 milligram, but rather the dose of 2 milligram. So this is for baricitinib. And regarding ritlecitinib, there are no such recommendations. However, we still need to perform examinations before treatment. This includes lab examination, X-ray of the chest, and the general medical examination. And then we need to perform this monitoring in certain intervals. So monitoring and qualification for treatment is important, as in other treatments.
These are side effects of oral applied substances. What about topical? Would there be a chance to use them topical?
Yes, there was a big enthusiasm about the possible efficacy of topical JAK inhibitors. This was because in mice studies, it turned out that the mice had a much better hair regrowth with a topical treatment compared to the systemic. However, our clinical experience does not confirm this. So we do not really have many topical JAK inhibitors which would be available, and only one which is approved. This is ruxolitinib, which is approved not for alopecia areata, but many of us have tried, and there is some hair regrowth, but it is definitely not satisfactory for either the patient or the doctor. There's tofacitinib, which is not marketed, but some of us make a compound type of gel. However, I think it still needs some work before we can use topical JAK inhibitors.
What about biologics? When we compare inflammatory diseases, the JAK inhibitors are there, but also biologics. Are there some in the pipeline also for alopecia areata?
Well, regarding the possibilities, I will start with the possibilities because there was a lot of hope for biological treatments. We were hoping for the possible efficacy of TNF inhibitors and other treatment that came on the market for psoriasis. They proved not to be effective. And then there was a lot of hope with the drug which we both know well, it's dupilumab, because there were some case reports about the regrowth of hair after dupilumab in patients who had atopic dermatitis. But this did not prove, and I will use the same word, statistical significant. So there are cases of patients who were described with an improvement after dupilumab, and patients who had a new onset of alopecia areata after being treated with dupilumab. So probably this is not a first-line solution. And yes, the pipeline or the search is wide. However, there is no such biological drug which would be close to be able to use in real life.
Well, one should not ask for too much. I think it is very exciting what we have heard, and that the JAK inhibitors are there. And would you like to give a message to the audience what is the most important things for our patients and for the field at the moment?
Yes, I will be happy to do it in a moment. Just to mention the new upcoming treatments, definitely there are new JAK inhibitors which are under development or partly already approved, because one of them is the ruxolitinib. It was approved in America, still not available, but approved. It was not approved yet in Europe. And maybe, who knows, upadacitinib, which is already approved for atopic dermatitis, is now under clinical trials for alopecia areata. So I'm really very hopeful for a new possibility in alopecia areata.
So it is a brave new world for our patients and for the people working in the area of hair diseases.
Definitely. If I can just summarize, I think what is most important is to understand the patient and to put yourself, I'm talking to doctors, to put yourself in the position of a person who is losing hair from one day to another. It is really a disaster moment in life, and please don't say it's just hair.
Thank you very much, Professor Rudnicka. And I think we have heard a lot of very interesting things, giving hope to many of our patients. Thank you very much.
Thank you very much.
Of course, all of the research presented today can be found in the Journal of the European Academy of Dermatology and Venereology. Though you can find free access and open access articles, EADV members benefit greatly by having access to articles and content. We would like to give a special thank you to all of our listeners. If you haven't already, make sure you subscribe on Apple Podcast, follow us on Spotify, or otherwise find us on any major podcast provider. We appreciate you joining us and look forward to presenting more interviews, research, and other topics of merit. Until the next episode, take care of your skin.